My name is Carrie Randabolio, and I'm Provincial Coordinator Knowledge Mobilization here at the Alzheimer Society of B.C. I'd like to acknowledge that I'm speaking to you today from our provincial offices located at what we now call Vancouver. This place is the unceded and ancestral territory of the Hunkaminam and Squamish speaking peoples, so that's the Musqueam, Squamish, and Tsleil-Waututh nations, and has been stewarded by them since time immemorial. On my bike ride to the office this morning, I was able to see lush cedar trees, wild roses in bloom, snow capped mountains, and even momentary glimpses of the ocean. I'm deeply grateful for the opportunity to experience the land's natural beauty and resources. And I recognize that this privilege comes from the stewardship and care of the Indigenous peoples who have lived here for millennia. And I'd like to give a big welcome to our guest presenter, Emily Dwosh. Emily Dwosh completed a Bachelor of Education degree from McGill University and worked briefly as a high school teacher in Montreal before completing her master's degree in genetic counseling at the University of British Columbia. She's worked as a genetic counselor at the UBC Hospital Clinic for Alzheimer's disease and related disorders since 2001 and has provided information and support to hundreds of families from across BC who are affected by Alzheimer's disease and other memory disorders. As a clinical instructor with the UBC Department of Medical Genetics, Emily continues to enjoy teaching medical genetics and genetic counseling. So, thank you again for joining us today and sharing your expertise with our community. We're so looking forward to learning with you. On the call is Dr. Sarah Wu, our strategic lead research, who will be facilitating the Q&A following Emily's presentation. Our new research and knowledge mobilization program assistant, Maya, will be keeping a close eye on the chat. So please pop any questions you have for Emily in the chat box, and we'll be keeping track for the discussion to follow. So without further ado, I'll turn things over to you, Emily.
Thanks so much, Carrie, and thanks again to the Alzheimer Society of BC for inviting me to speak today. It's my absolute pleasure. All right, so today we will be talking about a few major topics. We will start out by going through a bit of an overview of the role of genetics in dementia. Then we'll talk about genetic testing options and what the possible outcomes might be of genetic testing. We'll talk a little bit about what is genetic counseling and what might happen in a genetic counseling session. From there, we'll move into some research updates in the realm of gene-specific therapies for dementia, and then we'll move into the Q&A. So I'm hoping to have the content of my presentation take about 40 minutes or so. So hopefully we'll have a lot of time for all of your great questions. So just to review some terminology before we talk about genetics, dementia, as many of you may already know, is an umbrella term. It's a non-specific term that is used to describe cognitive change that is impacting day-to-day function. But what the word dementia does not tell us is why are those cognitive changes happening? And there's actually about 70 different reasons for why a person might have symptoms of dementia. One of those reasons is Alzheimer's disease, but other examples of dementia include vascular dementia, Lewy body disease, and frontotemporal dementia. These four dementia subtypes represent the four most common forms of dementia, but not the only ones. And as mentioned before, there's about 65 other dementia subtypes. For today's talk, I'm going to be focusing on these four most common dementia subtypes. When we think about Alzheimer's, vascular dementia, Lewy body disease, or frontotemporal dementia, it's what I always say first thing in my sessions is that most of the time, these conditions we would describe as being sporadic, not purely genetic. We describe these conditions as sporadic because most of the time they will pop up sporadically within a family. So there may be no family history of anyone else with that particular condition, and then somebody receives that particular dementia diagnosis. These sporadic, random chance diagnoses of these dementia subtypes, it's something that any one of us might get diagnosed with as we live our lives. And the underlying reason for the onset of the dementia in these sporadic cases is multifactorial. So these things are not caused by any one specific genetic factor or one specific environmental factor. Instead, these sporadic dementias are brought by complex combinations of numerous factors, including aging, lifestyle and environmental factors, and numerous genes that we inherit from both of our parents that set the stage for how vulnerable or predisposed we might be to developing that particular dementia in our lifetime. But these dementia subtypes that are described as sporadic, again, the emphasis is that they're not directly passed on from parent to child and they are not purely genetic. If we look back to the four most common causes of dementia, you can see the prevalence of the sporadic forms of each of these dementia subtypes. So, sporadic Alzheimer's disease represents about 95% of all cases of Alzheimer's. When we think about frontotemporal dementia patient populations, about 60% of the time, the frontotemporal dementia would be considered sporadic and multifactorial. When we think about vascular dementia or Lewy body disease, the great majority of the time, the condition will have this sporadic multifactorial cause or etiology. I'm going to spend just a little bit of time talking about Alzheimer's disease, the sporadic form that is the most common, just to really highlight that interplay between aging, genetics, and lifestyle. This dementia subtype, because it is the most common, is the one that we know the most about. And we have quite a good idea about what those lifestyle and environmental factors are that contribute to our chance of developing sporadic Alzheimer's in our lifetime. Things that you already might be familiar with that are on this list include things like mental stimulation, social engagement over our lifetime, good cardiovascular health, and that's where things like exercise and Mediterranean diet come into play, taking care of our sleep hygiene, our mental health, addressing midlife hearing loss, and avoiding head injury. Those are all things that numerous research studies have shown can play a role in how vulnerable or predisposed we might be to developing this common kind of Alzheimer's disease that we describe as being sporadic. And if we think about the role of genetics in this common kind of Alzheimer's disease, we've identified about 50 plus genes so far that we believe to play a role in sporadic Alzheimer's. One of these genes is a gene that you may have read or heard about. It's a gene called ApoE. And many people have heard of this gene because some of the direct to consumer genetics companies like 23andMe used to offer, they are bankrupt now, but 23andMe did offer ApoE genetic testing for many years. This is a gene that does play a role in how susceptible we might be to this common sporadic form of Alzheimer's. But whether or not you have the high or low risk version of this ApoE gene on its own is not a guarantee that you will or will not get Alzheimer's disease. It's just one gene out of many. And on its own, it doesn't give us enough information about your overall lifetime risk to develop sporadic Alzheimer's to be deemed a worthwhile genetic test. So we actually don't clinically recommend ApoE genetic testing as a means of predicting who among us will go on to develop this common multifactorial kind of Alzheimer's disease. In the links that I believe were sent out or will be available after the talk today, provided a really great comprehensive summary of the healthy brain aging strategies that have been implicated in dementia prevention. So if you're wanting to do what you can to prevent sporadic Alzheimer's disease, I encourage you to take a look at that resource. It's really fantastic. Okay, so let's go back now to our four most common causes of dementia. And I've talked about the sporadic forms of these conditions, but let's now look at the remaining cases. So, about 5% of Alzheimer's falls into this other category that we call familial Alzheimer's disease. About 60% of frontotemporal dementia we describe as being familial, and then less than 5% of all cases of vascular dementia or Lewy body disease would fall into this familial category. These familial cases are purely genetic in their cause, and they are something that we would expect to see more clearly running in a family with numerous people affected over the generations. Um, because this familial dementia is purely genetic, caused by a change in the spelling of a single gene, and that gene can be directly passed down from parent to child, the impact of having a parent with a familial form of dementia is going to be quite significant. And we know that if someone has a parent with a familial form of dementia, their own chances of developing dementia are going to be 50%. Now, why is it 50%? It's because all of our genes exist in a pair. So if somebody has a familial form of dementia caused by a mutation in a specific gene, they will only have that mutation in one copy of that particular gene pair. Their other copy is almost always going to be perfectly fine with no mutation. But the copy with the mutation is enough to cause the dementia. When that person goes on to have their own children, with each child they have, there will be just as much chance for them to pass on the copy of the gene with the mutation as it would be for them to pass on the copy of the gene with no mutation. And that's where that 50-50 recurrence risk comes from. We call this kind of genetic inheritance, where all it takes is one copy of a gene pair in order to manifest the disease, and then it can be passed down in that way, 50-50 chance. We call this dominant inheritance. So what do we know about these genes that can cause familial forms of these dementia subtypes? There has been quite a significant amount of gene discovery over the last couple of decades. For familial Alzheimer's disease, we know of three different causative genes so far: PS1, PS2, and APP. For familial FTD, there have been about 15 genes identified so far, and I've got those listed there, a few of them. They're in the familial vascular dementia category. There's also probably about 15 to 20 genes that we know of so far, one of which is that Notch3 gene I've listed out. Familial Lewy body disease, it is very rare, and there have only been two causative genes identified so far that lead to familial Lewy body disease. But very importantly, this listing off of the known genes is a work in progress. And we suspect that there will likely be additional genes discovered in the years to come that will get added to this list. So, what do we look for in order to figure out whether or not a person has the common sporadic form of any of these dementia subtypes or the more rare familial form? One of the key things that give us clues is the family history. So, what we're looking for would be family histories that have several relatives over the generations with the same dementia subtype. We're also on the lookout for younger ages of onset, and we're also keeping an eye out for conditions that may be related to these familial dementia subtypes. So, for example, we know that familial frontotemporal dementia has an association with ALS. So, we're on the lookout for ALS in the family, not just frontotemporal dementia. We know that familial Lewy body disease has an association with Parkinson's. So we're looking for both of those things in the family history. And for vascular dementia, there's that connection with the stroke history. It's not just looking for diagnosed cases of vascular dementia, we would also just be looking for history of stroke in the family. So the family history really is that first step. It can help guide our determination of whether or not someone might have a familial form of dementia. But we also recognize that family history sometimes doesn't tell the whole story. Family history can be complicated by things like non paternity, non disclosed adoptions, even just lack of information if family members live far apart and they're not necessarily in close contact. We also recognize that sometimes we won't be able to determine the presence of a specific dementia subtype going back a couple of generations because the terminology used to describe these conditions might have been completely different. The other thing that we're mindful of is that many of the genes that are known to cause these familial forms of dementia work in weird and mysterious ways. Some of them have what we call reduced penetrance. That means that a person can carry a mutation in the gene, but live their whole life and pass away at an advanced age of something else, having never manifested the dementia. Some of these genes also have what we call variable expression, where the mutation in that particular gene leads to different disease outcomes in different family members. So we might see in a single family, one person with the mutation developing dementia, but another family member developing another neurological condition. So the family history um, we do assess it quite carefully, and we're not too quick to rule anything out too quickly. Another thing that we always need to keep in mind when we're talking about any genetic disorder is that new changes in our genetic code are introduced all the time when egg and sperm cells are created. And it's possible that somebody may be the very first one in their family to have a genetic condition because a newly introduced genetic change happened in the single egg or sperm cell that became that person. So it's not a genetic disorder that's inherited through the generations. A de novo, a new genetic change that it's that one person is the first in the family to have it, but from then on in the family, other relatives, other descendants would then be at risk for the genetic disorder. So, just to give a couple examples of how we might interpret family histories, if we're wondering about familial Alzheimer's disease, what we would be looking out for in a family that would make us suspect familial Alzheimer's would be multiple relatives in the family with a diagnosis of Alzheimer's type dementia over the generations. So you can see here we've got affected grandfather having 3 affected offspring, and then of those affected offspring, some of them have affected offspring. And we're also looking in familial Alzheimer's disease for that younger age of onset. Onset prior to 60 is really the guideline for when we start to wonder about familial Alzheimer's disease in many family members over the generations. So this type of a family history would be a family that I would consider to be suggestive of familial Alzheimer's disease. If we're thinking about familial frontotemporal dementia, This would be a family that would be suggestive of that condition. As mentioned before, there's that connection with ALS. Some of the genes that can cause familial FTD, we know that mutations in those genes can, in some people, lead to ALS instead of FTD. So this is a family that has that combination of the ALS and FTD over the generations. Importantly, in this family, you can see how, I don't know if you can see my cursor, the woman with the arrow, who's the woman who would be my patient in this scenario, she reported that her mom is totally fine, even though mom's siblings and father were affected, and mom had two affected children. This would be an example of reduced penetrance. So, this mother, we would presume that she carries a gene change that leads to ALS or FTD, passed it on to her children, but she herself remained fine. And we do sometimes see that in familial FTD. There is clinical genetic testing for these familial dementias. This testing is not considered part of routine care. So at the UBC Alzheimer's and Related Disorders Clinic, genetic testing isn't done on every patient that comes through. It's something that is considered on a case-by-case basis. We rely on a number of out-of-province genetics laboratories to do these tests. There's no lab in Canada that offers these tests. The two that I rely on the most are listed here, Prevention Genetics and a lab called Invitae Genetics. And there's three options for how patients here in BC can access the testing. One option is to apply for MSP funding, and we have been getting funding approved in most cases recently, which is fantastic. If funding is not approved by MSP, we do coordinate for our patients private pay testing, and the cost is about $399 US. And then there's a third option that's a relatively new option, which is something called sponsored genetic testing, which is where a third party, like a pharmaceutical company or a research group, partners with a clinical genetics lab and essentially says, we'll cover the cost of patients' genetic testing, but in return, the patient needs to be comfortable with anonymized data sharing with that third party sponsor. Regardless of which route is taken for the genetic testing, there are some consistencies across all possibilities. So all of these are physician ordered tests. These are not things that a person can just order themselves, like 23andMe testing. So there must be a physician's involvement. The testing ideally starts with a person in the family who has the diagnosis of dementia, whatever subtype we might be talking about. And the labs that offer the genetic tests, we actually usually just use a saliva sample or a cheek cell swab. It's not a blood test, it's not spinal fluid, it's a saliva sample. And then we could order a test that looks at numerous genes at the same time, or we might hone in on one particular gene if we're most suspicious that that's the reason for the dementia in the family. And the turnaround time for results is between 2 to 4 weeks. Prior to testing, genetic counseling can be helpful for families. It's not required. A physician can order these tests for a person who has the diagnosis of Alzheimer's or FTD, et cetera, without pre-test genetic counseling. But the genetic counseling allows for some exploration of the test implications and limitations. The connection with the genetic counselor allows for a detailed review of the family history, determination of what are the chances that this might be a familial form of dementia. It also ensures that we're choosing the right genetic test. And then we can go over what are the limitations of that test, what are the possible test outcomes. And it's really a means to ensure that any family who's considering genetic testing is making an informed choice about that testing process. So, some of the factors to consider prior to testing are things that I would go over with a family in every pre-test session. What are the family's motivations for testing? What are they hoping to learn from that genetic test? How might the genetic test results impact the patient in terms of their clinical management or our understanding of what symptoms or other things we might expect in terms of that patient's progression? We talk about the potential of insurance implications for family members, the impact of the genetic test results on other family members and relationships with other family members, and also, how those test results may impact a person's psychological well-being, not just the patient themselves, but also their family members. Are their offspring, their children, truly prepared to potentially find out that they have a 50% chance of being at risk for the same condition? So, if a family decides that, yeah, we do want to go ahead with the genetic testing and we arrange for testing in our patient, um, possible outcome number one would be we get a negative test result. No mutation found in any of the genes that we asked the lab to look at. If we get a negative test result, that provides us with some additional reassurance that that patient's condition falls into the category of the sporadic form of that particular condition. But there's always the caveat that that person's dementia could still be familial, but perhaps caused by a mutation in a gene that has yet to be discovered. If we have a negative test result in our patient, then we would not offer any genetic testing to their family members. If we don't find a gene change in the patient, there's no point in looking for genetic changes in their relatives. The other possible test outcome we would describe as being a positive result. So we find a genetic change in that patient, and that's the determined reason for their dementia onset. That will confirm that they've got a familial form of their condition, that it is purely genetic. It would also allow for that confirmation of the 50% recurrence risk for each of that person's offspring and siblings. Most likely, the positive genetic test result won't impact the patient's clinical management, but there are some additional options that do become available for the patient and the family. So, one of these options that now becomes available is the option of predictive genetic testing for that patient's family members. This kind of predictive testing is called predictive because we're offering the testing to people who don't have any cognitive symptoms, so it's not a diagnostic test. It's giving people information about their future, predicting what they may be at risk for down the road. And it would be available to all family members of someone who gets a positive test result, as long as they are legal age of majority. So predictive testing is not something that we would ever offer to a child. And when someone is having predictive testing, pre-test genetic counseling is required in these scenarios to really ensure that people are well prepared psychologically and with supports in place to adjust to and cope and understand what that means if they get a positive result. Other options that become available for family members if we get a positive genetic test result in our initial patient would be reproductive and family planning options, including options for prenatal testing or assisted reproductive technologies, such as in vitro fertilization with pre-implantation genetic diagnosis. So there are private fertility clinics that offer these services. And the other thing that may then become an option for the patient who had the testing and possibly their family members would be clinical trials. So there are several gene-specific clinical trials underway in this world of familial dementias. There are studies taking place pertaining to familial Alzheimer's disease, familial frontotemporal dementia. Another condition that we didn't talk about today, a more rare genetic dementia called familial prion disease. And then there's others that are sort of in the pipeline that likely will be up and running in the near future. And all of these trials have different approaches, but they have the same ultimate goal. Can we improve patients' symptoms and slow down their disease course? And is it possible that early administration of these therapies in individuals who carry genetic mutations but don't yet have neurological symptoms, could these therapies actually prevent the onset of disease entirely? So I'm just going to mention a few of these trials. So one trial is called the DIAN trial. It stands for Dominantly Inherited Alzheimer's Network. This is a group of researchers based out of Washington University School of Medicine in St. Louis, who are focused on familial Alzheimer's disease. And they are currently running some trials that are enrolling individuals who carry mutations in one of the three familial Alzheimer's disease causing genes. Participants in this trial are being given therapies that target the two proteins that build up in and around the brain cells when people have Alzheimer's disease. So specifically the amyloid and tau proteins. So it's a gene specific trial in the sense that it's only enrolling people who have genetic or familial forms of Alzheimer's, but this is not a gene therapy, which you're going to talk about next. The therapies being trialed are not acting at the level of the gene, they're acting at the level of the protein buildup. But there's a lot of hope actually with this trial. The Diane group has been active for many, many, many years. They've had some preliminary findings that look quite promising. And UBC is actually one of numerous recruitment sites around the world that is enrolling participants for this Diane clinical trial. So if there's anyone on the call today who knows that they or their family member have familial Alzheimer's due to a mutation in one of those three genes, and they're interested in learning more about the trial, they're more than welcome to reach out to our trial coordinator directly. Her name is Michelle, and her email address is posted there. If we now move into gene-specific clinical trials that we would describe as actual gene therapy that work at the level of the gene. I've got a couple of those to share with you today. One is something called antisense oligonucleotide or ASO therapy. There's some ASO therapy trials taking place that are looking to treat familial forms of Alzheimer's, frontotemporal dementia, prion disease, another rare genetic form of dementia called Alexander's disease, and a few others. These ASO therapy trials, the majority of them in the world of dementia are developed by this company, Ionis Pharmaceuticals, that sometimes partners with Biogen Pharmaceuticals. This is their main area of focus. Unfortunately, there are no UBC isn't yet a recruitment site for any of these ASO therapy trials, but there are some recruitment sites in other centers across Canada. And now I'm going to do my best to explain how ASO therapies work. So before I talk about the therapy, let's back up a bit and think about the function of our genes. So many of our genes work as blueprints, instruction manuals for building a specific protein product. And these proteins that are made within our cells, we need them for the normal function of that cell and to keep those cells healthy and working. The process through which a gene's genetic code is read by machinery in the cell and turned into a protein product, we call that transcription and translation. So keeping that in mind, now let's imagine a situation where, for example, someone has frontotemporal dementia because they have a mutation in their C9orf72 gene. So that person has a change in the spelling of their C9 gene. Transcription and translation happens, and the copy of the C9 gene with the spelling mistake results in an altered protein product. And that altered protein product then leads to the onset of familial frontotemporal dementia. The way ASO therapies work, the therapy itself, you can think of as being a little snippet of genetic material that is created to match a gene of interest, and sometimes even a gene mutation of interest. The therapy is introduced directly into the nervous system through lumbar puncture. And what the therapy does is it interferes with transcription and translation. So then you get reduction of the altered protein product. And the hope is that then that will prevent the onset of the familial FTD in that patient. So I hope that made sense. There has recently been a success story of ASO therapy. I know that this made the news back in March. There is a drug called tofersen, which was just approved in Canada for a genetic form of ALS, which specifically is caused by mutations in a gene called SOD1. So that same collaboration I mentioned earlier of Ionis and Biogen Pharmaceuticals, they are the drug companies that created this tofersen therapy. It got FDA approval a couple years ago, and Health Canada just approved it in March. It has been shown in ALS patients to have a modest effect in slowing down the progression of the ALS symptoms. Where the research is now heading with tofersen is a clinical trial that has enrolled about 150 people who have SOD1 mutations who don't yet have ALS. And those individuals are being given tofersen and monitored over time in the hopes that that very early administration of tofersen before the ALS symptoms have occurred, we might be able to see delaying or prevention of the ALS onset entirely. Another kind of gene-specific therapy is something that we would describe as gene replacement therapy. And there is a gene replacement therapy trial that is taking place right now that has enrolled individuals who have familial FTD because of a mutation in a gene called progranulin. The way that this therapy works is by introducing a healthy working copy of the gene into the nervous system using a harmless viral vector. There weren't any Canadian sites for this gene therapy trial, but I did know of at least one local patient who participated through the US site. So it is possible to be part of trials that aren't happening locally. And the way that this therapy works, again, bear with me, it's a little bit different, but it still goes back to that basic principle where we've got a gene, transcription and translation happen, you've got that protein product, and then we need that protein for healthy cells and cell function. In people who have familial FTD because of a progranulin mutation, in those individuals, the gene mutation itself, even though transcription and translation are happening fine, the mutation leads to actually no protein product being created. It sort of stops that the final step that has to happen before that protein is created. And because there's no progranulin protein product, those people end up developing familial frontotemporal dementia. The way the gene replacement therapy works is that you've got a healthy working copy of that progranulin gene introduced directly into the nervous system. Transcription and translation happen within the cell using the healthy copy of the gene so that you get the normal protein product creation. And then the hope is, again, that that will prevent the onset of the frontotemporal dementia. So, again, I hope that made sense. So, there's a lot of excitement and promise in this realm of gene therapy for familial dementias. It's early days, but I really do think that there's reason to be hopeful for the future, and I'm quite hopeful that we're going to see more promising advancements in the next, I would say, 3 to 5 years in this realm. For anyone who is curious and wants to sort of stay on top of clinical trials regarding familial dementias, you can check out this website, clinicaltrials.gov. On the homepage, you'll see a search engine, and you can just enter a specific form of dementia. And if your family knows of a particular gene change that's in the family, you can enter the gene name, and then you'll get a list of all the current clinical trials that are happening. And then I always encourage patients and families to, talk with their clinician or their genetic counselor about the legitimacy of the trial, the science behind it, who's running it, and get just a bit of a double check to make sure it's all looking legitimate. But the clinicaltrials.gov website, they usually provide the contact details for the site coordinators, and people can reach out directly and get all the details. So to summarize, most dementia is sporadic and multifactorial. There are, though, those rare cases that are familial or genetic. Clinical genetic testing for familial dementia is available, and there are some gene-specific trials now underway, and accessing genetic counseling can help you understand your options. If anyone in the audience is wondering about the role of genetics in either themselves for their own diagnosis or maybe their family history, anybody can access genetic counseling services at the UBC Clinic for Alzheimer's disease and related disorders. It just requires a referral from your family physician or your specialist, and the referral information is on our website. If any of you are already being followed at the UBC clinic, I'm here. I'm happy to meet with anybody. You just need to call our main reception desk and just let them know that you or your loved one is a clinic patient and you're seeking a genetic counseling session, and our clerical staff will arrange the appointment. My wait list for new referrals is unfortunately getting a little bit lengthy, about 8 to 10 months for new referrals, and I do most of my sessions by Zoom. So happy to see people from all over the province, make it easy for them. So thank you so much, and I look forward to all your questions.
Great. Thank you, Emily. I think you covered some great information in a very accessible way. So appreciate that. Um, okay, so we do have, so yeah, if for those who have been on the call, please submit your questions for Emily and we will try our best to get to all of them. So we'll start with Mary had a question. Is frontotemporal dementia hereditary?
So frontotemporal dementia, if we think back to the umbrella diagram and the portion of cases that we describe as familial versus the portion that are sporadic, the split for frontotemporal dementia is that about 60% of the time it's sporadic, multifactorial, and about 40% of the time it's familial. Or yeah, familial, and we would expect to see one of those gene mutations as the cause. So it can be genetic, but it's not always genetic. It's still most often sporadic and multifactorial.
Hmm. Okay, thank you. We have another question from Roma. she's referring to terminology. So I've heard both types of dementia and causes of dementia. And are both terms acceptable? Or maybe we can just talk about the differences between those two terms.
Oh, that's such a good question. I know that the wording of all of these things is so complex. So I think that I would answer that question to say you could use those terms interchangeably. So if we think of dementia as the umbrella term that is just describing a clinical presentation of cognitive change impacting day-to-day activities, there's numerous reasons for that cognitive change, including Alzheimer's, including FTD, and so on and so forth. Those are examples of causes of dementia. They're also examples of subtypes of dementia. So I hope that's clear.
Yeah, that was a great answer. Thank
Okay.
you. Um, we have a question from Linda. Um, if a husband and a wife, so age 78 and 75, both have Alzheimer's disease, as well as other relatives on both sides of the family, does that increase the risk of Alzheimer's disease for their children, ages 45 and 43?
Okay. So that kind of a question. My first, if we were sitting in a genetic counseling session, I would take the full family history for both sides of the family. If the Alzheimer's disease in the family members was late onset after 60, 65, we wouldn't be highly worried about it being familial Alzheimer's disease. We would be looking at those two parents who both have Alzheimer's at a later onset, because you said they were 78, so I'm
Mhm.
presuming a later onset. So we would think, okay, those two parents have the sporadic, common, multifactorial kind. But then that question of, well, what does that mean for that next generation in that family? We do know, even for sporadic forms of these diseases, because there's at least some role for genetics in the sense of all of us walking around with numerous genes that make us more or less vulnerable or susceptible to these dementias. Having a close relative, even with sporadic forms of these diseases, does mean statistically that our own chances of ending up with that form of dementia are going to be a little bit higher than the general population. I compare it to people who've got heart disease in the family or type 2 diabetes in the family. We can see families where there's a bunch of people all with heart disease or all with type 2 diabetes. Those diseases are not purely genetic. They're usually multifactorial, caused by combinations of aging, lifestyle, and genetic vulnerability. We can see those conditions clustering in a family because of shared environment and shared genetic vulnerability. But that doesn't mean that other people in the family are destined to get
Mhm.
heart disease or diabetes. And if they take care of themselves and they eat well and they exercise, they could live their whole life and never get heart disease or diabetes. So it's the same principle with sporadic cases of Alzheimer's. If you have it in a family member, if you have it in a couple family members, yes, we can't deny that you probably have a bit more vulnerability as compared to someone with no family history of it. But it definitely is not your destiny to get Alzheimer's disease. And if you focus on some of those lifestyle factors that I listed before and that are on that resource I mentioned, you can mitigate that genetic vulnerability through lifestyle.
Mhm. Okay, thank you. And for our audience, these are such great questions. And I just want to say that if you have a more specific question, because some of them get a little bit tricky, they're quite individual. Happy for you to send your questions to us, and we can forward them to Emily. So I just want to put that out there. Um, okay, we have a question from Eva. Um, so if you have dementia in two generations of a family, but it happens in your 70s or 80s, it's not likely genetic? That was a question from Eva.
It depends on the dementia subtype.
Mhm.
So, absolutely, if it's a family history of Alzheimer's disease in the 70s and 80s, we would not be worried that that could be familial Alzheimer's. But if it's a family history of frontotemporal dementia in more than one family member in the 70s or 80s, the age of onset in FTD doesn't matter as much. And so if it's FTD in more than one family member, we actually don't pay attention to age of onset at all. Just having the FTD diagnosis, regardless of age of onset, would make us wonder about the possibility of it being genetic.
Okay.
I hope that
Okay.
makes sense.
Thank you.
Yeah.
Yeah. We have a question from Samantha. She wants to know if something's coincidental. So, is this coincidental? Different dementia. Um, okay, so different dementia, Lewy body, grandmother, Alzheimer's disease, father, great uncle, unknown. Um,
Yeah. So great question, because one of the complexities in interpreting family history is the fact that getting a diagnosis of any of these dementia subtypes can be tricky. There's not an easy test. These are medical conditions that even today in 2025, we can't actually know for sure if someone has Alzheimer's or Lewy body or FTD unless an autopsy is done after passing. And even though an expert physician, like a neurologist, a geriatrician who has particular expertise in this field, they get the diagnosis right most of the time, we do acknowledge there can be overlapping and similar symptoms. And so when I meet with a family and take the family history, if I'm wondering, could this be familial frontotemporal dementia, but then there's a family member with reported Alzheimer's, unless there was an autopsy to confirm that, I would bear in mind the possibility that maybe that relative with the Alzheimer's diagnosis actually had frontotemporal dementia.
mm-hmm.
We do allow for that diagnostic uncertainty. So if there's any concern about the role of genetics in a family history of dementia, the best first step is to gather as much information as you can about all of your relatives who had dementia and try to tease out, who made the diagnosis, how clear are we that it was correct, were there any autopsies done to confirm it. That kind of information is so helpful for us to tease out what might be going on.
Mm-hmm.
A family history of dementia, we only worry that it's potentially familial when it's the same dementia subtype. If we get medical records, autopsy reports, and it was Alzheimer's in one person, stroke-related dementia in another, and Lewy body in a third, we wouldn't be worried that that's a genetic form of dementia. It's a family history of dementia due to different types. But if there's any possibility that there was a misdiagnosis there, or there's no autopsy confirmation, we keep an open mind.
Okay, thank you. We have lots of questions coming in. And just noting that we may not be able to get to all of the questions, but happy for people to forward their questions onto us. Again, I'll put an email up at the end. We can forward them to Emily. Okay. We've got one from Lori. My father has been diagnosed with multiple system atrophy. So there is so little information on this disease. Is this related to Alzheimer's?
So, first of all, Lori, my heart goes out to you because I know that must be a hard diagnosis to get for the family as a whole. That's a really rare condition. You're right. Multiple system atrophy is actually, it's connected not with the Alzheimer's disease world. It's connected more with the Lewy body Parkinson's disease world, because the brain changes of multiple system atrophy have to do with a protein building up that's called alpha-synuclein. And that's the protein that builds up in Parkinson's disease as well as Lewy body disease. So it would be under sort of that realm of related conditions. Most cases of multiple system atrophy are sporadic. It would be unusual to see it running in a family. However, if you were to be referred to me for a genetic counseling session, the first thing that I would ask you is, what's going on in the rest of the family? Are there any other people with symptoms similar to, I believe you said it was your dad? Is there a family history of Lewy body disease or Parkinson's disease? We would have to take into account some other aspects of the family history to best answer that question. But off the top of my head, what I can tell you about MSA is that it's usually sporadic.
Okay, thank you, Emily. And thanks, Lori, for your question. Okay, Cindy has a question here. My mom, her two siblings, her mother, and her grandfather have or had Alzheimer's. My mom is currently in late stage. It sounds like my mom would need to be tested before myself or my siblings. Is she right about that?
Yeah, you're absolutely right. The testing ideally would start with your mom. Her DNA would be analyzed for mutations in the known familial Alzheimer's genes. Only if a mutation was detected for your mom would you then have the option of informative predictive testing for yourself, because then we would know exactly what we would be looking for in you. So it provides you and the rest of your other family members the option of the most informative testing for yourself if that was something that you were interested in. If hearing that makes you interested in proceeding with genetic testing for your mom or just wanting to learn more about it, I know I said that the wait list is 8 to 10 months for new referrals, but I always triage individual cases one by one. And if someone gets referred and they're already in later stages of their dementia, I would triage those to be seen as soon as possible so that we're not missing any opportunities for testing if the family wants to go ahead with that.
Okay,
So your
thank you.
mom could be referred to the clinic for genetic counseling. It would be under your mom's name, but I would do the session with the family.
Okay, thank you. I'm cognizant of the time, and I'm also noting that there are several other questions. So again, please feel free to forward those questions to us. Um, and I'm actually going to go ahead and share my screen now um, as we uh, look to wind down today's session. Okay.
Sarah, can I interrupt quickly?
Absolutely.
I'm just looking at the chats. Someone asked about genetic testing in Ontario, Toronto specifically.
Mhm.
Um, there's many medical genetics clinics in the Toronto area that would offer and be able to coordinate genetic testing for familial dementias. One in particular that I know they have some genetic counselors there who specialize in neurogenetics is the medical genetics clinic at North York General Hospital. So if you just Google North York General Genetics, you'll get the website, and then you could bring that to your family doctor or your affected family members specialist and request that referral.
Okay, that's great. Thank you for that.
No problem.
Um, Thanks for catching that last one. Okay, and I'm just going to open up the chat because I have some things to throw in. Okay. Um, well, we'd like to say thank you, Emily. Like this was truly an informative. I've learned a lot from this session with you, so thank you so much. It was accessible and you did such a great job of answering people's questions. Um, and thanks to all of you for joining us today. We hope that you enjoyed the webinar. We always love to hear from you. So like I said, if you have other questions that you'd like to send to Emily, please get in touch with us. I'll just throw our research email there into the chat. Um, And if you're wanting more information about dementia or wondering about programs and services offered through the Society, please give our first linked dementia helpline a call. Our operators can support you in English, Punjabi, Cantonese, and Mandarin. And we also really appreciate hearing feedback on what you think about these Research Connects webinars. We have a survey set up specifically for this webinar series, and we do our best to try to take your feedback into account. It takes 5 minutes to complete. The link is in the chat. So if you could click that link so that it opens up in another window before you close the webinar, that would be awesome. We'd love to hear from you. We'd also like to flag that on August 20th, we'll be hosting our next Research Connects webinar entitled Highlights and Headlines from the 2025 Alzheimer's Association International Conference. And so Carrie and I will be there both presenting, but also to gather information to share the biggest news from that conference in Toronto, July 25th to 31st. So you will be getting new findings hot off the press. AIC is actually the largest international conference on dementia research and features insights from world leaders in this area from across the world. You can find additional details about that webinar, including a registration link at alzbc.org/webinars closer to the date. And we also encourage you to visit our YouTube channel to watch previous Research Connects webinars that we record and upload for your viewing. So our portfolio supports research recruitment both provincially, but also nationally and internationally. And I have 3 opportunities today that I would like to share with you. Researchers at the University of Waterloo and University of Alberta are wanting feedback on people living with dementia and care partners on what they think about a mobile app they're calling GuardIO. And it was developed to support community safety and help prevent people from going missing. So if you'd like to participate in this study, it would be, downloading the app and then sharing with the researchers what you think about the app. You can get in touch with Dr. Antonio Miguel Cruzat, and I will be sharing that contact information with you in the chat in just a moment. Haley O'Neill is completing her PhD at University of Wilfrid Laurier in Ontario and is conducting a study to understand the current resources that are available to family caregivers of those people who are living with young onset dementia. And so if you'd like to participate in that, you can reach out to Haley, and it would involve completing an online questionnaire. And finally, an in-house project that we are collaborating on with Emily Carr's Health Design Lab and the University of Victoria. And we are inviting biomedical researchers and people affected by dementia to participate in an online workshop to identify ways in which biomedical research can be more dementia inclusive. So our goal is to create complementary resources for both researchers and people affected by dementia to promote more inclusive practices. So if you are interested in that, you can please reach out to me and I can provide you with more information. And I'm just going to grab that information for you, and I'm going to throw it in the chat right here. Okay, there we go. And also just wanted to flag, engaging in research activities can make a really big difference in your community now and also for future generations. And so if you want to find out more about how to be involved in research, we actually have a webpage dedicated to that. It's called I Want to Participate in Research. alzbc.org/research, or you can just use your phone and hold it up and grab it from that QR code right there. So the Alzheimer Society Research Portal and also Reach BC, those are 2 sort of platforms where researchers can post research opportunities for you to engage with. So I encourage you to check that out. So with that, I'd like to thank you all for calling in today. I'd like to thank Emily Dwosh for a wonderful and informative presentation. We look forward to seeing you the next time on August 20th, and we are wishing you a sunny and pleasant summer months. So thank you so much.
Thank you, Sarah, and thanks to everyone for your great questions. If we didn't get to your questions, they can be forwarded over, and then I think they'll be forwarded to me, and I'll do my best to get back to people accordingly. Thanks again, everyone.
Absolutely. Thank you.